Hello everyone, welcome. Today we have speaking Christopher Levi, who is a neurologist by training, a clinical trialist, and currently the executive director of Sphere. So he's going to talk a little bit about the strategic platform development through Sphere. So, Chris.
Thank you, Rebecca. Good afternoon, everyone. Really great to be with you, and I haven't been in this building for a long time. I was a medical student here, and it was always a scary place to come because the dean used to live downstairs in this little outhouse out the side of this building, and whenever you had to go in there, it was always a bit spooky. I was never in trouble. I did graduate, but I remember going in there a few times, but it's certainly changed a lot since I was here. So it's a magnificent campus, and I'm very fond of this university and this institute. Of course, the Kirby wasn't here at that stage, of course. It's a much younger entity, but I've been well briefed on all your achievements, and I had the great pleasure of meeting the late David Cooper last year when I started, and we an absolute gentleman and a scholar, as I'm sure you all knew him very, very well, and it was tragic. But it's really great to be here in Sydney. I've been many years in Newcastle, as Rebecca sort of mentioned. I started my research career here as a BMed science year in advanced mouse strangling and rat strangling, somewhere across there in the biological sciences building. And but I never really kicked off in basic biomedical science. I went into clinical sciences and trained in neurology and in stroke research. So I guess I bring an understanding of research world. I'm a program grant holder, practitioner fellow. I do some serious research, but I have very limited knowledge on the biomedical side of the fence. But clinical trials is something that I do, and I bring that interest in sort of research inside healthcare to this job, because one of the real passions I have is to see the great sort of clinical laboratories that we have, such as the one across Botany Road there and all the others that we have in Sydney and across Australia, sort of harnessed more effectively for research, but also to see research embedded more effectively within those organisations, either physically or virtually, because I know the benefits that patients will accrue from that, not only in accessing latest treatments, clinical trials, etc., but also wearing my stroke hat now, the penumbra of benefit around that, which is now well and truly well understood. In other words, the science, the epidemiology of clinical improvement now is well recognised to spin off embedding research in healthcare, better outcomes for patients all around. So I'm going to talk about what Sphere's trying to do in that space, and just to acknowledge the traditional custodians of the land, and Sphere's Indigenous name, it's a Dalek name, Maridulu Budyari Gumal, which is working together to promote good health and well-being. We were gifted with that name. I'm very proud of that, and the people out Parramatta Way who live by the river there were the genesis of the name. So you can see our partnership there is a broad one with 14 partners, and all those partners have invested in Sphere and have provided a cash contribution towards this mission, which I'll tell you about in detail in a minute. But essentially the mission is to drive translational research, but more importantly research translation to impact. So that's the sort of mantra for Sphere. And you can see some well-known local entities there on the list as you screen across. But the three unis, UNSW, the largest, and the group of 8 UTS and Western Sydney, they're also great assets in terms of research engine room, and some fabulous institutes, obviously including the Kirby being nested inside UNSW. doesn't have to put up an individual financial commitment, which is very good. You're covered by your good friends that across there in the Chancellery. But we're part of a broader ecosystem. There are 9 of these centres now across Australia, and these were foreshadowed in the McKeon Review in 2013 and have come to fruition. They are of 2 types. The big metro centres are called ARTECs, Advanced Health Research Translation Centres, and there are 2 regional centres. And the New South Wales Regional Centre was a centre that I essentially blueprinted and established in the Hunter, and then jumped the Hawkesbury, came down here to work. And the Central Australian Centre are the 2 regional centres that have a slightly different focus. Obviously they don't have the same research engine rooms as the big centres, but they have the same translational mission. And there's now an alliance of these centres across the country, and that alliance is looking to work on a number of cooperative national programs. I won't talk a lot about that, but there's a lot of good work going on now across the centres, and the centres are now, because of their collaboration, largely are attracting investment from MRFF to support national systems level initiatives. And Sphere's leading one in health services improvement and sustainability. So why do we need advanced health research translation centres? And you could ask, why don't we just sort of carry on as we are? Well, this is the view of many of us who've got an interest in this sort of big picture consortium world, that we're in and have been for many years, in a environment where the drivers that we all, as say an institute director or a vice chancellor or a health service chief executive, are being tasked with delivering on, are actually not providing the environment that we need to maximise better health through research. The LHDs and health services, particularly primary care, have these sort of commercial drivers. It's not a private health system I'm talking about, but they're driven predominantly by the need to deliver service against activity targets within a capitated budget. In primary care, of course, it's private business largely that's driving that system. Universities and MRIs are being driven by completely different metrics. There's no metrics that are really driving them, although now, as you know, the impact metric is beginning to get some traction around what's your research actually going to deliver in terms of a future impact on healthcare, and what's the commercial potential impact of your research. So these things tend to be pulling us apart and not bringing us together. And broadly, the mission of the ARTECs is to get more of alignment of purpose around some of this stuff, and to get a virtuous cycle of research actually providing better care for patients, and that better care for patients then being returning to healthcare improvements in efficiency and effectiveness, so they can do more with what they've got, and they deliver better quality of care. The whole driver for this, of course, as most things, is Treasury wanting to take a bit of the accelerator off the growing costs of healthcare across the country. So that's really what we're trying to do here at a sort of macro level. So these centres are a fundamental sort of change in the interactions at all levels. When I say that, I'm talking more about the scale. So the really good institutes and the really good unis have really strong links in aspects of their interaction with healthcare, but it's not large scale, it's not programmatic, it's not at the level that these centres are trying to drive it. So that's what I mean by a fundamental change that goes across disciplines, geographies, institutions, sites, and that has a very patient sort of centred view. So we're focusing on how our work can benefit patient outcomes, bringing together research and innovation with education and clinical quality, all on in one sort of construct. So this is actually a slide from Ian Jacobs, who has led 2 of these partnerships in the UK, and has been instrumental in Sphere moving to be the only significantly invested partnership in the country. And to be honest with you, that's the attraction for me, that there is financial underpinning to Sphere that allows the Sphere executive and the council to actually do things that are potentially going to make a difference. And the whole idea is you bring the universities, the health services, primary care, the MRIs, and in some aspects commercial partners in to drive the cycle, the virtuous cycle. But particularly, this is an important point here, that the focus is very much on applied research and what the clinical needs are, feeding back to set some agendas inside the academic engine room. Not all agendas, but some agendas, because you certainly can't ever disinvest in discovery science and blue sky work. You need that. That's the foundation of great discoveries, and that's not what this is about. This is about aligning some of the clinical needs with some of the research and innovation through a programmatic approach. And if I conceptualise the Australian version of Ian's slide that I showed you, which was based on his UK experience in London and Manchester, this is how I see it. We have our traditional research and innovation engine rooms, and we have there now hospitals and our primary and community care and our population health groups. And we have the traditional pipeline from discovery through to adoption and diffusion. And there's the dominant role for these centres is out towards that sort of applied definitive testing and adoption and diffusion end of the spectrum. This end of the spectrum really isn't broken. We have a phenomenal research engine room, such as your institute and others. The problem's out at this end, where we have problems with translation, we have problems with clinician behaviour change, we have problems with adoption of best evidence practice, we have problems with issues that aren't being addressed on the research agenda. So the whole idea here is we orientate a little differently for some of the work that we do. And the platforms I'll tell you about are sort of designed to achieve that to some extent. So the first thing that Sphere did under Ian's leadership, this was before my time, but this was a sage move, was to establish programmatic leadership in currently 12 clinical academic groups, they're called, or CAGs, that address big burdens of disease and adhere to the sort of mantra of cross-disciplinary, cross-geography, across the spectrum of discovery to implementation. And you can see them there, and the Kirby would have roles across a number of these, but a very strong role in the infection, immunity and inflammation CAG. And in fact, Tony Kelleher, as you know, is the leader of that CAG, and a number of you are key players in that CAG on the executive and driving strategy in that CAG. And Rebecca is the fearless executive officer for that CAG. So you're all doing a fantastic job in that CAG. And the CAGs had their 12-month review just about 3 weeks ago, and the performance of the III CAG was incredibly strong, and was up in our upper echelon of CAGs. So we did measure. We didn't tell you all the scores, but we did measure, and you guys were very good, very strong. You can see we've got great breadth, and the engine room underpinning those CAGs is on the whole pretty stellar. And when I think about what, for instance, when I reflect on what I had in Newcastle, in Newcastle HMRI compared to the engine room you've got here, it's unbelievable what you've got here. And we've got to be capitalising on it more inside health, and that's really my job to do that. So that's the Sphere mission, to integrate research, education, practice across partner organisations to improve health outcomes and drive better healthcare. But essentially, if you look at that south of the harbour and you look a little east, south of the harbour, that's ours. That's our turf. So it's about 2 million people. It's about 50,000 staff. It's a big swathe of the country, and it's a challenge. But my job is to work with you guys to try and achieve this sort of getting some of the work that you need done inside health for translational benefit. So the first 12 months of Sphere has really been about getting a plan right and doing a sort of standard strategic planning process. And we're now up to this point here. So I've defined some strategies in consultation, and I'm going to tell you about those strategies now. You don't need to read all that. And the strategies really are focused mainly on where there's gaps and where my constituents have said to me, you need to do something here because we've got a problem. There's a barrier, there's a gap that is disabling either translational research, which is that sort of research that's going to lead pretty soon to something delivering in healthcare, or that research translation, which is taking the research results and moving them into practice, which requires a science of its own often, which I'll come to in terms of the term implementation science and knowledge translation. So, and I put the little boutique sign up there because there are lots of really good small scale things happening across Sphere, across all over the place. And there's nothing, and they're great, but the whole mission for Sphere is to take things and move them at scale to across that part of Sydney that I showed you. So there are many good small scale initiatives, but often they remain within those silos. And there's also great national schemes in terms of the fellowship schemes and the partnership project grant schemes and various other schemes that are designed to try and bridge these gaps. But they're really, as you guys know, highly competitive and difficult to really get at. And there's also not a lot of money if you think about the NHMRC budget and where most of it goes. There's not a lot of money going to this sort of work. So there are numerous issues and gaps that could be addressed, and what I've done is I've chosen, at least in this first phase of the Sphere platforms, what I think are some of the key gaps, and I'll tell you about this in key strategies to address some of the gaps, and I'll tell you about those. So how Sphere will roll out later this year and into the next 3 years is essentially to support the CAGs, such as III, with what will be our foundational enabling platforms. We have 12 foundation CAGs, as I showed you, and we will bring on a couple of new CAGs next year in some areas where we have opportunity but also big gaps. And I'll let you know what those are. There's a vascular health is a huge gap in Sphere. We need to address that, and that'll happen. The great interest and linkage between the technological world and the healthcare world, we'll capture that in the Frontiers Technology CAG. And also that we'll capture this evolving area of health and the built environment with a health and built environment CAG. So those are three going to be targeted. There'll be an open call as well, and you'll see that come out soon. You've already got a CAG, so you don't need another one, but others will be interested in putting up for a CAG. But I'll focus today, I won't talk about the CAGs, I'll focus on these platforms. So these are the platforms that we'll roll out first, and I'll walk you through them in the next 20 minutes or so. The Workforce Development Platform, this is an important one, as you know, because it's always all about the people. A clinical innovation capture program that's going to orientate or bring researchers and clinicians together around clinical issues and problems. This Supporting Leading Better Value Care program is to align ourselves as an academic sector with the Ministry of Health's request that we do look at comparative effectiveness studies, do health economic analyses of models of care, and that we start to choose wisely in that space. an implementation science and knowledge translation platform, and also clinical trial support. So the workforce, and I've just grabbed these out of our strategic plan. So these are busy, but you don't have to read it all, but I'll talk to it. So many of you who are clinical academics in the audience will know that we've got a real problem with that workforce. We have a sort of an ageing and declining volume of clinical academics. If you look at the metrics on the medical side, it's getting into worrying levels wherein ideally the sort of standard metric is there'd be one sort of professorial level, high performing, grant holding, fellowship holding clinical academic for every 20 jobbing clinicians. That's roughly the metric. Some of our hospitals might be close to that, but many are not, and most would be below that. That's in medicine. In nursing, we've got no idea. In allied health, again, we've got no idea, but we know that in both of those areas there's a deficiency. So coming back to us in the planning phase, look, we've got to do something about this. It's been on the agenda of the South East Sydney precursor of Sphere, SART, and it was a big focus for that consortium when it was in its developmental stages before Sphere. So we're going to invest in a fellowship program that will essentially provide salary support for clinical scientists, clinician scientists, clinicians or clinically applied scientists working on projects of relevance, well supervised, enrolled in traditional high degree research training, and training people properly to become clinical scientists, clinical academics, or scientists focused in the clinical domain. The pipeline into that will be what I've called a research internship program. So the people that would go into the fellowship program would be that sort of early to mid-career type of person, and they'd be expected, hopefully, to pick up within a couple of years a national competitive fellowship and give me back some of that money, and I can then recycle it. So I hope we set up a virtuous cycle there where I'll be able to leverage then an NHMRC fellowship or a New South Wales fellowship and come off the Sphere money. But there needs to be a pipeline before that. One of the problems we have is that the kids these days coming through medicine, nursing, allied health, they really don't see this as a viable option, going from $80,000, $100,000 a year down to like what I did when I was bloody registered, down to $25,000 a year on an NHMRC scholarship, and they won't do it these days. It's just not, you just can't do it. You just can't survive on that sort of money. So what I've done is I've created a situation here where we can give them a taster with this and move them through a term or an attachment or an allocation that gives them a sort of makes them supernumerary to the clinical service and allows them to work with a research active unit. The key to this working is that only those research active or research intensive units will have the honour of having a research intern. You can't put a research intern with a pedestrian outfit, otherwise it'll turn them off research and they won't get anything out of it. So that's the pipeline that would lead into the TRFs. Those calls will come out soon because I want to move this into the cycle of recruiting for 2019. So there'll be a call for fellows that will come out to end of August, early September, so that they can think about next year's career with that in the mix of their thinking and lock themselves in. The internships I won't put in place till next year because essentially we've got a lot to do there. And these are challenging because I've got 4 LHDs to work with here. And 4 LHD workforce units, and the mechanics of doing this is, those of you who've worked in the health service would understand, not easy. Innovation, don't have to read all this again. I'm just going to focus on The initial bit that we're beginning to roll out now is it's point 2 here. These are these facilitated workshops that we've called the RICH outcomes workshops. RICH stands for Researching Important Clinical Issues for Better Healthcare Outcomes, and it's a process by which clinical ideas and issues are identified, curated, and then the research engine room is brought to bear on them, and a small project grant is generated, undergoing pretty rigorous peer review as it is worked through. So it's softly contestable, if you want to call it that. So these projects are beginning now to roll out. These sort of small project grants are beginning to form, and they'll be funded and roll out. And I know that Rebecca has orientating the IIICAG to attack some of these, and bringing her clinicians in and linking them up with you. You guys will be doing some stuff around diabetic foot infections, and we'll be doing some other stuff we just talked about today around linking the clinical pathology labs and the biomedical pathology labs around some shared issues. So that's Rich Outcomes Workshop, and then the larger scale piece of work will more be working with the uni and the MRI's business development units to try and bring industry in more to health, and to try and link up clinicians with good ideas. Most of these clinicians will be surgeons and proceduralists, and try and link them in more effectively to an invention, incubation, proof of concept, proof of value, commercialisation pipeline. That won't happen until next year, and there's lots of players in that space. Now I'm going to spend a lot of time on clinical trials, because I know that Kirby's a trials engine room and incredibly accomplished in that space. I just wanted to tell you what my thinking is there and what we're going to do. So some of you would have seen that the New South Wales Ministry Office for Health and Medical Research has put out this framework for clinical trials support unit that they want to see develop inside each of their local health districts, or more correctly, each of their large hospitals that runs clinical trials. And I support this. I having tried to run clinical trials in hospitals for many years. It's a tough game, and they're not all that supportive and helpful, and you can waste a lot of time and effort. So this is the concept, and Sphere's going to help with this and lift some things up and promote some aspects of this. There are 4 quadrants. There's a clinical trials liaison officer concept. This is like front of house, open for business type of arrangement, and it's a good idea. However, it's something that I think we need to lift up a little higher, and we're going to look at having a broker across Sphere to link into this person and bring the world, particularly the industry and the funded world, in. Hospitals run clinical trials finance appallingly badly, so there needs to be a management accountancy element, which we can talk about if we want to, but I'm not going to spend a lot of time on that. Then there's the day-to-day running of trials, recruitment, down this quadrant, the day-to-day running of trials and getting good quality work. That has to be at grassroots level, and I'll come back to that. But this quadrant here, the lower left quadrant, they've called trials services, is really something that individual hospitals do not have the capability really to do. This is high quality design, methods, stats, health research, economics. Your average Prince of Wales, Liverpool hospital, they do not have the capability here. So the concept here is we would work as a Sphere partnership with the groups that we have, such as the Kirby, the Ingham, the George, and other pockets of excellence, to actually make this a reality across Sphere, but to shift it up to a supra LHD level. And I'll come back to the detail. So in the plan, we want to focus on the design, the conduct and the financial benefit, but also have an open door to the world approach. So we move from the sort of more the very boutique cottage industry to a much more organised and programmatic way of running trials. We also want to make sure that there's public awareness and that there's a promotional sort of campaign broadly around the benefits of engaging in trials and you and your relatives participating in trials. So this is all in scope, and I'll tell you some of the details of this now. So I have a great support person running this program for me. That's Rowena Tucker, and these are Rowena's slides, and I'll walk you through what she's doing so you're familiar. Some of you will already have been asked to be involved in this, and I thank you for doing that, because we need your thoughts and input into this. But what she's done is really done a scan, and she's looked at what the capacity and capability is across the Sphere partnership, identifying some strengths and weaknesses and barriers. So all that's happened in the background in the light of that framework that I showed you from the ministry. The environmental scan, literature review, all this has been done. She ran a workshop in June and brought a lot of people together there to listen and basically take advice from the interested parties, and there'll be a second workshop in September that'll have a bit more focus around it, and we'll begin to socialise the ideas that I'm going to show you now as to how we might move forward. And then there'll be steering committees formed that will actually develop recommendations that I'll take back to council, and I'll get the investment ratified to do the work. So there's as you would imagine, a governance process around all of this money that our universities and institutes are putting up for us to use. So I talked a little about the design. I think this is the most exciting thing, and I really hope that we can pull this off. What we do will only be able to be seed funded initially, because the amount of money that I can put towards this over the next 3 years is probably in the order of about 2 million. So that's not a lot of money, but it's enough, I think, to get proof of concept, and then to bring in more money, hopefully from state or from Medical Research Futures Fund, if we start to get some proof of concept and some evidence. So what I want to create is this, essentially this sphere-wide design method stats research economics support service for the membership, for the broader membership. And as you guys know at the moment, I mean, you've got pockets where you've got excellence in that space, but you've got many groups who would be willing clients and would be happy to pay for such a service, but at the moment they don't know how to access it and produce the quality grants, produce the quality protocols, get the money in to run their academic trials. So the steering committee in this space will bring together what I call the academic CROs. The Kirby would be one of those, and look to how we can really bring together the expertise to form this sort of virtual service. So that really is a key piece of information for you guys, because you're right in the middle of this, as is the George, as are a number of other groups such as the Ingham and the Scientia. And I hope that steering committee can deliver some recommendations, and then we can set up this one-stop shop sphere-wide service with some core funding that I can put up to support this to happen, and then have some sort of sustainable cost recovery model to maintain it, but ideally bring in more money. This all sounds a bit socialist, but I think this is worth a try, because I think this is going to work if we can actually show the proof of concept with the money that we have inside Sphere. The conduct piece is divided into two, and there's a boring piece that many people have tried over many years to achieve, and most people wouldn't go there again, but I'm going to go there again, and that is a one portal entry point for ethics and governance across sphere. So all the ethics committees and all the site-specific approvals have a harmonised approach. I see you laughing and thinking that this is nirvana. But no, we're going to have a crack at this again. This is the sort of thing sphere is supposed to do. We are supposed to work on this and try and get this right. So I have I've put my top man on this steering committee, Professor Terry Campbell. He's running this steering committee. It's his job to sort this out. So Terry will have a plan to propose to council, and ideally all those research support and development officers in all those LHDs will have bought into that plan, and we'll then be able to move this forward next year. There's some other work going on around compliance and some auditing work, which I won't bore you with at the moment, but we're doing that as well, because that's what that will support the grassroots research officers. So that's the harmonised ethics and governance. Then the third steering committee, which I'm going to chair, because this is a particular interest of mine, is how to enhance recruitment. So how to improve that trial opening to first patient recruited time point, which is a bloody disaster across Sydney at the moment, which many of you in Nottingham will know. And then how to recruit to target. What have we got to do better here? At the moment, we're functioning like a cottage industry, seriously. We are really seriously underperforming here. Not that trials run out of the Kirby, I'm sure, but trials run broadly across sphere are just pedestrian in this space. So there's a lot of literature out there. We've done a literature review. We're going to bring to the steering committee what works, what could we pick up in sphere, what could we actually invest in sphere to achieve this. And again, it'll be seed investment, and I'll be looking to leverage from OHMR, from MTP Connect, from Active, from other groups around the country to try and bring a bit of money in to help us. But because we've got scale and you know, we've got half of Sydney's population here to service, I mean, we're serious. And if we get something working, I think we can leverage some investment. So that's my job. This is some of the other sort of deliverables out of my working group, to sort of get more health service executive sponsorship, to get more clinician leadership inside our hospitals, promoting trials, and to make sure we have better career pathways for our research nurses and allied health who are doing all the work in sort of coordination. Those career pathways for those people are they're really suboptimal. They don't get looked after well. They're on these rolling annual contracts. There's no sort of longer term pathways for them. So we want to try and fix some of that. Again, requires the connectivity to health, requires all the challenging stuff that unis and MRIs just can't do because they're not linked in. Whereas what I can do is get in there inside the health service and try and tweak some of this. Requires trust and requires the health services to be on the bus with us, and that's what we're doing. And I'm pleased to say at council we've got really great engagement from the healthcare chiefs. We've got to get down to the middle management level now and start to get that engagement there. And included in my patch is actually enhancing community sort of engagement with an understanding of trials. So we'll be working up some sort of promotional package that we'll use to link out into the community. Not so much into primary care. I'm drawing a little boundary there at the moment because that's an even more challenging place to go. But certainly to pharmacists, we've linked with the Pharmacy Guild, and we have other links into various community health and community service groups. Again, just some of the detail around what we're going to do in terms of that community links. We do have links to the PHNs, and the PHNs are ambitious in this space, but they also haven't gained any traction in terms of getting out there into primary care and creating research networks in primary care. It's very difficult to do because they're small business operators and they've got to turn a profit, and research rarely turns a profit for them. And then do the national engagement work with groups like ACTA. So there's a lot of detail there, and I'm happy for as Rebecca said to me, she hadn't seen this detail because I hadn't shared this before, but this has been the work that Rowena's been doing the last 3 or 4 months just to put all this together in preparation for the steering committees. So I'm happy for you to share this, Rebecca, with the membership. Just to finish off, so these Leading Better Value Care are comparative effectiveness research grants. So these are essentially traditional research grants, but they'll be pushed out in targeted areas to look at evaluations of models of care, essentially. And this is a Ministry of Health sort of mantra at the moment, that we should be doing comparative effectiveness research, we should be measuring also patient-reported outcomes and patient-reported experience measures, PROMs and PREMs. So these will be project grants, essentially, that will push through the CAGs. So Triple I will get an opportunity to contest for these in areas that you want to focus on. There'll be not so many of them, but there'll probably be 4 in the first call in October. They'll be about $75,000 a year for 2 years. So they're decent money, not little bits of money. But everything's seed money. As I say, targeted calls around this sort of value-based care area. That'll be the sort of overarching concept. So again, very clinically applied projects. And finally, or almost finally, the implementation science and knowledge translation platform. So I won't dwell a lot on this, but essentially we've identified 2 leaders. One is a nurse academic in implementation science, Sandy Middleton, and the other is a psychology academic from the Black Dog. Sandy Middleton is from St Vincent's, psychology academic from the Black Dog, Catherine Boydell, and they are putting together this platform. This will be an academy of experts, or community of practice, or whatever you want to call it, but I call it an academy of experts, where projects will be able to tap into this and have a card-carrying implementation scientist, knowledge translation expert linked to their projects. And some of you might be collared for this if that's your penchant, because at the moment there are very few people with these skills, and we need to grow this. So there'll be some small grants as well, and there'll be an education training program spinning off this platform. So I won't, mindful of time, I'll take some questions, but that's essentially what this platform is going to do, the virtual academy experts, and also the education and training program. And finally, and some of you are already tapping into this, I've kept some funding aside for support for the CAGs to partner up on partnership grants or ARC linkage. So I think this is really important, because it's often hard for you to get money out of healthcare, and the secret is I've got their money and I can send it back to healthcare and back to you in a partnership grant if you've got a good idea that is going to be acceptable to healthcare. There's a process you have to go through to justify this, and there's a form you fill out and you get it back to us, and that's just the process there. Rebecca can help you with this. And we've had a very good application come from Jason. Where is he? There he is, Jason. That is looking good for this upcoming round, and I've almost exhausted all my money for this current financial year. At least I've committed it. So if you get the grant, you'll get it. If you don't get the grant, then let me know as soon as you know, and I can free it up for another application. But yeah, that was a very good project, Jason. So, and I liked your style, and you had it beautifully organised, and it was easy for me to look at it carefully and go, yep, ticks all the boxes. So so that is there for the CAGs to use. It's more or less first in best dress for that. I have to just judge what comes in. There are the 3 rounds for NHMRC partnership a year, and I may well next year try and hold a little back and keep some for the later round. It's a bit tricky, but we'll see how we go with that. But that's all I wanted to say. And in summary, the platforms are really there predominantly to drive through and help the CAGs with their mission, and provides sort of platforms that provide support that goes across all the CAGs in terms of things that are identified as being need-based, and things that a CAG itself, with the budget that it has, can't necessarily do. The CAGs don't get a lot of money. As Rebecca knows, it's about $500,000 over 3 years is the funding, and it's all seed money. So these provide a bit more investment, and hopefully, as you see these roll out later this year and early next year, you'll be able to capitalise on them. And hopefully these will provide you with what you need to better connect into healthcare, and will provide healthcare with that sort of understanding of the mission. So at the moment we're still on a bit of a culture change inside health. We're still on a journey where middle management in health is beginning to understand what its role is in the research piece. And it's not a big part of their role, but it's a part of their role that really didn't exist before Sphere, and before we started to push in and essentially provide some investment in there. And I guess without the money you can do nothing, and we've got a bit of money, so we can begin to make those inroads. So I hope at the end of this next financial year you'll begin to see some benefits from these platforms, and we'll be reviewing them and looking at their effectiveness and deciding whether it's worth continuing with them. Not so much the end of next year, but certainly the end of the year after that. That'll be the point in time where we make a call about that. So I'll wrap up there, and happy to do some Q&A, Rebecca, if there's any questions.
Would anyone have any questions?
So, Chris, can you tell me a little bit about future CAGs? So are you looking at cardiometabolic or cardiovascular, and how are you going to advertise this and get people into it?
It's a good question. And this is a challenging issue. When the foundation CAGs formed, there was and this was before my time, but Ian Jacobs sort of, I think, massaged some groups together. Some were very logical, like the UNSW themes that were immediately already gelled, and some were new, and these will be new. So what I've done is I've put together 3 communities of interest, you might call it. Nominated leaders from the 14 partners who have expertise in those 3 areas, and it's vascular health, so it's broad. It's not restricted to cardiovascular. It's a broad brush, and I want it to be all-inclusive, although we do have a diabetes, obesity and metabolic CAG, so that there's some aspects of vascular will be there, and there's aspects of vascular, some aspects across some of the other CAGs as well, such as in the neuroscience, mental health and addiction CAG, and in the age and ageing CAG, and there's bits and pieces. But I want it to be a broader church. It will naturally have a cardiovascular sort of core to it, I think, because we have amazing firepower over at the Chang and at St Vincent's in that space, right? So I think that's a logical core to it, but I don't want it to be exclusively cardiovascular. And what I've done is I've brought a group together initially around the UNSW non-communicable diseases theme, and then Vlado will be bringing some additional groups interface with that, and I think we'll then have a coherent group form. The other 2 areas, the frontiers technology and the health and built environment, have been a dream, and it's been a great pleasure to bring those groups together. The biomedical engineers and the clinicians get on like a house on fire. It seemed to be a marriage made in heaven, that one. I've been very happy with that one, and the health and built environment one's been really pretty virtuous as well. So both those leadership groups are forming now. The call will come either very end of August or the first week of September. And it'll be a single stage process with an external review and an announcement in November. External peer review. And a pretty lean application, won't be an onerous application.
So I guess I have one comment and one question, and Chris didn't ask me to say this, but I think it's important for people thinking about putting in applications for the pilot funding. So, when you look at it, it's, okay, 75K, it's not a whole lot of money, but because Sphere has built-in relationships with all the LHDs, it was actually incredibly valuable to be able to have that 75K go to the services in those local health districts and say, look, I've managed to cobble together 75K. You provide me a day of clinical support for this project. I'll give you research support. I'm not going to fund clinicians because I want this to sustain once the project's done. And they say, yeah, sure, I'll give you a day of support if you give me a day of research support to cover that extra. Then you go to industry, if you have industry partners and say, look, I can't fund this, I've got this catalyst. Will you then provide the in-kind machines, testing cartridges, whatever it will be? And they say, yeah, okay, fine, we'll do that and provide the in-kind. So after 75K, you're actually able to leverage perhaps several $100,000 on top of that. So just think about when you're crafting your applications, how do you fit bits together to then create a whole? And that was really successful because it allowed then next stage, okay, partnership project. Okay, everybody's already engaged, the partners are there, they've already been part of the process, so it was quite easy then to move into like a partnership versus partnership project. So just a little bit for people to think about, because I think that's relevant for you guys here. So sorry, Chris, I just thought that would be
I'll just say your strategy was, as I said, it was exemplary.
Thank you very much. So my question for you is, you mentioned a little bit about industry partners, and it sounded like more on the discovery end. Maybe I'm wrong, but I'm just curious, have you talked to any of the health funds, private health funds, and is there any appetite for, you think that would be a logical group of industry that would want to decrease costs around hospital stays and, what is being paid out? Has there been any discussions with the private health funds, and is there any appetite for investing in sort of research that will improve better care and improve patient outcomes?
I haven't as yet talked to the private insurers. I've had some talks to philanthropy and as you say, more pump priming the discovery end. And these are difficult issues for Sphere because everything I do has to value add on the partner's work. And the unis, the MRIs, less so the health services, they're all in this space. And I must be careful not to compete or be seen to be getting in the way of the partners' sort of, negotiations around industry partnerships and co-funding and the rest of it. So to be honest with you, I've left the enterprise part of Sphere to the very last piece of work that I begin to do, and that'll be next year. So the research and the education bit I've focused on, the enterprise bit, Sydney Partnership for Health Education Research and Enterprise. The first 12 months I really have not touched it. So it's work for me to do, but that's a good idea actually to target that group.
John.
Chris, thanks for a great overview. Probably about a million questions I could ask you. I'm trying to think of the most useful targeted one for our organisation. So you pointed out some ways that the Kirby Institute could get more involved, and obviously we're involved as individual projects and that kind of thing. But a lot of our work is population health, and this is very much a hospital focus, as you've indicated.
Yeah.
We do have hospital trials, but there's particular networks that are already in place for those that are national and international, and I don't know how much we'd actually gain by going on board with some more in our area. But you put forward the idea of a sort of a CRO type, or academic CRO, which I think it sounds good in theory, but has some concerns in practice, because what is the benefit for the individual researchers that want to get involved in that, apart from just providing a service? I mean, if it's a fee for service, that's one thing, but it's not really an academic necessary. I mean, if you're just doing it for some other academic group that's got their interest, there might be ways to find mutual interest. But there's a couple of other areas that I think we do have real strengths in that you sort of either alluded to or haven't. And I've just mentioned a couple. So one is you're talking about the pipeline of training for early researchers. You didn't talk about sort of coursework structures for clinical researchers, and I think that's something which we can offer very, very much is expertise in the sort of coursework that people need to get into that pathway and early mentoring and how to kind of line, and that's something which I've had a bit of a chat with some of our III colleagues in the hospitals about this, but we haven't gone far enough, but how to really find those people, but also just provide them that bit of extra confidence and either choose short courses or kind of extended or repeated short course offerings. That's one. The other thing I'm not sure where it fits in is, which I already thought was going to be part of Sphere, but I haven't seen it quite explicitly, is sort of upgrading of the, what you might call the routine data sets that are available throughout the hospitals and how to make better use of more observational research rather than the trials. And so that's something which we also have a lot of expertise in and a lot of interest. So a couple of areas, and we've talked about implementation science. Implementation science builds totally on those sort of databases. So there's a couple of areas I think we could really support you very strongly.
Yeah, so the population, I'll come back to the final two bits. The population health primary care domain isn't lost to me, isn't lost to Sphere. It's just that I need to bring in some more partners to have traction there. So I'll be bringing in our 2 PHNs into the Sphere partnership shortly. And that will provide us with, that executive support out there in the community that we don't have at the moment. It was a bit of a strategic mistake not to have them in the foundational council, and it's a clear gap. So I would love to develop a primary care research network that groups like the Kirby could capitalise on. Yes, and that's in scope. But I need to bring the PHN leadership into the council first, and then think about what investment we can put out into that space. Yeah, the academic CRO is a challenging thing. It is, as I said, this sort of socialist ideal, but what's in it for the hardcore groups like yours and the George and others? What's in it for them? And I think this is what we've got to work through. This is exactly what the steering committee's job is. I've asked Vlado to lead that steering committee, and I need really to float this and just see what comes. I've seen it work quite well small scale in the Hunter, but I think this is a scale 4 or 5 times that. So we have to see what comes and get the balance right between the academic interest, collaboration model, and then the fee-for-service model and how we blend something around that. And I think we can do it, but it's tricky. I agree with you, it's tricky. And the final question is about the informatics piece. Yes, I didn't talk about it because there's the one thing that I couldn't work out what to do when I did all the scanning was how to achieve this that you're pointing out. So what I've done, what does the CEO do when he doesn't know what to do? Engages a consultant. So I've engaged a consultant, and there's a piece of work going on at the moment about what we should invest in. And I think it will be something along those lines.
It's not always just about data, about computers, by the way.
No, I know.
It's systems, yeah.
I know.
And then the other thing is about the training, the research training.
Oh yeah, sorry. And so what I see is that if we get fellows or interns, even more importantly the interns, the younger ones, but certainly the fellows, they will enrol formally in a program, and that program should encompass coursework. And that's where
that doesn't exist now. We need to create it.
We need to create it, yeah. And that's what will be part of the fellowship program. They'll have coursework requirements, and most importantly, have mentors to provide them with that sort of understanding of their future. So that I've seen it many times, not amongst you erudite immunology folk, but so a public health. A cardiologist goes into his research high degree training, does a nice PhD, masters, whatever. Where does he go? Off into private practice, right? You know, and off they go, bang, bang, bang. Procedural specialists, surgeons, many other physicians as well. Never use it again. Never use it. Oh, well, might use it on their plaque. You know, but you know, this is the problem.
Need more socialism.
I'm just touching on with the academic CRO, but no, you know, and we need to address this. I mean, we all talk about research waste. That's research waste, you know. But it's a lucrative world out there. And Sydney, there's a lot of one thing I've noticed compared to Newcastle, a lot of very comfortable people in private practice in Sydney who might have been great clinical academics, but never sort of had the pathway through. So
Thank you very
see if we can
much.
fix it. Thank you for listening, and I'll report in again one time.
Great.